if you do neuro, one of the first things someone asks you to do is to do a lecture on the Sella and paracellar area. So almost everybody has one, and I've got one also, and I'm going to try to make it relatively simple because that's my level of understanding. It's relatively simple. So we'll talk about micro and macroadenomas. We'll mention null adenomas. We'll talk about some of the clinical syndromes, not too much. I'll talk about an algorithm for a young woman that comes in with amenorrhea. We'll talk about the variable appearance of craniopharyngioma, and I hope we have time to just talk about chordomas for a second. So if you do a lot of neuroimaging, you should expect to see, in a significant percentage of patients, incidental lesions. And some of those incidental lesions are going to be related to the Sella and paracellar region. They're going to be related to the pituitary gland. And someone's going to ask you, could that be a non-functioning microadenoma? That's the question that comes up all the time. So we can have incidentally found lesions. We can have a patient that presents with an endocrine problem. The most common one that we typically talk about is amenorrhea, galactorrhea in women who are currently menstruating. We also talk about acromegaly and gigantism and Cushing's disease. The NIH has a study section for ACTH secreting microadenoma, so they see a lot of them. The thing that I didn't know is that you can die from an ACTH secreting microadenoma. You're not going to die from a prolactin secreting microadenoma. So, and then we'll talk about mass effect symptoms and everything. So we heard Satchmo. So this is great. I love mnemonics, except I can never remember what the darn letters stand for. It's like Satchmo. Okay, now I start making things up. Okay, S. Okay, sarcoid. A. Okay, there are vessels, aneurysm. But what I'm doing when I make up what the words are that go with the letters is I'm just thinking geographically about what's going on there and then throwing in some inflammatory and other things. So, but this is the mnemonic we commonly use. Who was Satchmo? Louis Armstrong. Some people of our age remember Louis Armstrong. Most people don't. His nickname was Satchmo, Satch or Pops. This is what he looked like. His career began to fade before all of our trainees were born, et cetera, et cetera. So that's Satchmo. This is another one I found, most ache. I'm going to stick with Satchmo myself, but this is just rearranging the letters a different way. So Sella and paracellar lesions, just to think about it, adults get different tumors from children. Children are likely to have craniopharyngiomas and hypothalamic gliomas and optic pathway gliomas, and adults are likely to have pituitary adenomas, and they may also have a different flavor of craniopharyngioma, but we have to think about all of these different things. So a little bit of anatomy. We have the cavernous sinuses. We have the cranial nerves embedded in the wall of the dural reflection around the cavernous sinus. So we've got 3, 4, and 2 branches of 5. The third branch, the mandibular branch, has already left the building, so it's not going to show up. Imagine that you're the trigeminal ganglion hiding here, and somehow you've got to get your viral particles to pass through the subarachnoid space in the dura to infect the uncus. I'm still a little skeptical about that. But just, a little bit of basic anatomy there. The abducens nerve is hiding inside the sinus. If we had really ultra-high resolution, we'd know that there is a distribution of the different types of pituitary secreting cells in different portions of the gland. ACTH tend to be near the midline. And you want to remember that the gonadotrophs and the prolactin-secreting tumors and the growth hormone-secreting tumors, those things can be a little bit lateral in the gland itself. And of course, ADH comes from the posterior pituitary. We all know about the posterior pituitary bright spot. AJNR, American Journal of Neuroradiology, article was published in the early days of MR about the pituitary fat pad, that bright fat area in the bright against the dorsum sella. I remember opening up the Blue Journal, seeing that article, running up 6 flights of steps in the AFIP building, running into the neuropath guy's office and go, is there a fat pad in the pituitary gland? And they said, what the heck are you talking about? So we know it's actually the neurosecretory granules that are in the posterior neurohypophysis. So, if it's bright, it's normal. If it's not bright, that may be associated with diabetes insipidus. So Again, we have the normal anatomy we have to think about. We've already heard about the aptochiasm and the mammillary bodies today. So let's just talk about pituitary adenomas. Now, pituitary adenomas come in two big flavors. They come in the macroadenoma, which is merely a size criteria, bigger than 10 millimeters. If it's bigger than 10 millimeters, it can grow out of the sella turcica and into the suprasellar cistern. And if it's typically bigger than 16 millimeters or extends 4 to 6 millimeters above the diaphragma sella, it can press on the chiasm and give us that classic bitemporal hemianopsia. So we want to remember that. Microadenomas, how are we going to find a microadenoma? Well, it's either going to be an incidental finding or it's secreting something, and the patient has an endocrine presentation. So that's the way we're going to find it. Now, let me just stop for a second and ask a question. How many of you think that women are more likely to have prolactinomas? Just, no one has a functioning upper extremity. So that's what we've all been taught. But you need to know that prolactinomas as a histologic findings occur with almost equal frequency in men and women, and men don't respond to the prolactin. We're all comfortable with having amenorrhea, okay? It doesn't bother us. So this is an interesting finding when you talk about the difference between clinical syndromes, imaging findings, and the actual pathology that's going on there. They're all a little bit different, but we want to talk about this. So pituitary adenomas, they have a relatively high prevalence, 15% of intracranial tumors at autopsy. This includes symptomatic, asymptomatic, incidental, et cetera. More than a fifth of patients on imaging if you do high-resolution imaging. Functional adenomas are 5 times more common than non-functional ones as a assessment of the tumor histologically, not necessarily the patient having a clinical syndrome, et cetera. So lots of information there. So let's talk first about microadenomas. Again, these are small, so they're not going to present with mass effect. Theoretically, they could be under a centimeter and cause panhypopituitarism by compressing the rest of the gland in the sella turcica, but that's very uncommon. So they can be incidental where the patient presents with a clinical syndrome. So again, they're usually going to be in adult patients entirely within the gland. The prolactin symptoms, decreased libido, infertility, osteoporosis in both men and women. Oligomenorrhea is probably more common than actual amenorrhea. Galactorrhea can occur in men and women, which is not the same as man boobs that we see when we go to the water park rides here at Disney. And then erectile dysfunction. So these are all things we have to think about. But you want to think about the endpoint for your diagnosis. So what's the current best therapy for prolactin-secreting tumors? You give some kind of a drug, right? You give the patient some kind of a drug. You're not going to do surgery. So do you have to do a whole lot of really interesting imaging to be able to decide that the patient has an elevated prolactin and they're going to get bromocriptine or cabergoline or something to treat it, and then you can watch it shrink? Because I think sometimes we're just chasing the imaging when it's not going to make a difference for how the patient is treated. So we can think about that. But this is a very, very old Doonesbury cartoon. But basically, the patient comes in with an endocrine symptomatology, and we work them up. So, 33-year-old woman, menstrual cycle abnormality. So she had oligomenorrhea, not amenorrhea. She had a little bit of galactorrhea. The first question should be, is she pregnant? If the answer is yes, then give her some folic acid. She's going to get prenatal care. If she's not pregnant, then they measure the serum prolactin. Is the serum prolactin over 500, or is it like a couple hundred, or is it a normal level? By the way, the normal levels for men are very similar to normal levels for women for prolactin. So if it's not elevated, then you can watch the patient. If it's elevated, does she have visual symptoms? Then she probably has a macroadenoma if she has visual symptoms. And if she doesn't have visual symptoms, does she have galactorrhea? And if the answer is yes, then she could have a microadenoma, and then you have to do some special study, right? You want to do some kind of a time sequence by MR to be able to look for that flip-flop. So is she pregnant? I was surprised to find out that porpoises can tell if women are pregnant. I don't know how often they do that, but porpoises can actually tell. And we don't really know if this harms the fetus or not, but they can tell. So anyway, this patient's pregnancy test was negative, serum prolactin was elevated, greater than 1,000. She has to have a secreting tumor to have it up in that range. So that so-called stalk effect that you may have heard about is typically less than 200 for the elevation in prolactin. So serum prolactin levels, 0 to 20, in the third trimester, they get up to over 400, but then that she's pregnant. Adult men, again, it's in that same range, 0 to 15 nanograms per milliliter. Stalk effect is typically less than 200. This is something you hear all the time. Something is pressing on the stalk can cause elevated prolactin. Lots of drugs can cause elevated prolactin. So everybody who has a prolactin-like syndrome does not need to have imaging. So anyway, we want to think about those complicating things. So this is the laundry list of drugs that can elevate prolactin. So all kinds of antipsychotic drugs alter the physiology of the brain, and they can cause it to go up. So it's very important to think about all of these other potential complications. Now, macroadenomas. These are going to present with bitemporal hemianopsia. They may be functional or non-functional. So what I was taught, which might be what you were taught, is that microadenomas are common in women and macroadenomas are common in men. That was the first thing that they told me. And then they said that the macroadenomas were non-functional. Well, that makes a little bit of sense, because if the tumor was making some kind of a hormone, then the patient could have had an endocrine presentation before it got to be big. But if it's not making any hormone, or it's making a hormone that doesn't give you any symptoms, then the tumor can get bigger and bigger and bigger. Now, some people don't mind being large, so growth hormone secreting tumors as opposed to prolactin secreting tumors, patients don't like being the tallest kid in school, so they could have a growth hormone secreting tumor. They may not think that that's a symptom. And the big tumors, of course, can be subject to degeneration, hemorrhage, and necrosis, et cetera. So most macroadenomas actually do secrete hormones as a biochemical finding, but it may not be It may not be one that causes clinical symptoms, and again, the most common one secreted is prolactin, and the patient may also not respond to those hormones. So again, you're talking about either it's not making a hormone, it's not making a hormone now, or it's making a hormone that the patient doesn't respond to. But in terms of the imaging, we talk about the snowman sign for the macroadenomas. We talk about how there's a constriction. I've heard several different explanations for why it has a waist and looks like a snowman. Explanation number one, it's the residuum of the diaphragma sella. Probably not a terrible idea, but maybe it's growing through the vessels of the circle of Willis, and that somehow is constricting its growth. But large heterogeneous mass there for pituitary macroadenoma. So think about this snowman here, and hopefully I won't talk about it again, so we're not going to have Groundhog Day. But let's think about some other things that are in the region. An enlarged stalk. There's a differential diagnosis for an enlarged pituitary stalk, and it sometimes is related to the patient having symptoms. The patient may be postpartum. They may have lymphocytic hypophysitis. You can have CSF seeding. We spend 2/3 of our day upright. It shouldn't be a surprise that if things are circulating in the subarachnoid space, they might sink down into the suprasellar cistern. So CSF dissemination may give you lesions that are going to be involving the hypothalamus and suprasellar cistern. Intracranial germinoma in the pineal gland is thought to do that, but intracranial germinoma can also arise primarily in the suprasellar cistern. Don't know exactly the embryology for that. If you have a kid with diabetes insipidus, you know there's two kinds of diabetes, right? Have you ever seen that old skit where they pass around the urine to the medical students and the professor dips a finger into the urine and tastes it and then passes it on to the students to ask them what it tastes like. And if it's diabetes mellitus, it tastes sweet. And if it's diabetes insipidus, it's like a bad wine, insipid yet dull. But what the professor was trying to teach them is he didn't lick the finger he dipped in the urine. He licked a different finger. Their powers of observation were terrible. But they all got a taste of that. But anyway, if you have diabetes insipidus in a child, you want to pay attention to look for that posterior pituitary bright spot. Germinoma, lymphoma, sarcoid, TB fungal, as we said before, those all can be in the suprasellar cistern. So differential diagnosis for an enlarged stalk. Again, if the woman is postpartum, it might be lymphocytic hypophysitis, some kind of an immune-related phenomenon to them having just delivered a baby, but it's the same group of things that we're talking about here. So diabetes insipidus, again, there's central causes as well as peripheral causes, making too much dilute urine, but lymphocytic hypophysitis, postpartum up to a year later, they may get generalized pituitary insufficiency, and they may have enlargement of the pituitary gland. So we need to think about that. Here's this case where the pituitary looks enlarged and the stalk looks enlarged, and this was lymphocytic hypophysitis. So let's go on and talk about Rathke's cleft cysts. How many of you have seen a Rathke's cleft cyst? They're there all the time, aren't they? Weren't we so lucky when the slice thickness didn't show us all of this stuff? Now we're seeing this and everybody goes, what do I do with it? Is it going to grow? Is it going to kill the patient? Am I going to get sued? Is it really a Rathke's cleft cyst or is it something else? Geez, these are the questions that philosophers have argued about for centuries. But you're going to see these little non-enhancing things on a post-contrast scan in the pituitary gland, and it might indeed be a Rathke's cleft cyst. Now, I've seen Rathke's cleft cysts that were like 6 centimeters in diameter, and nobody had Rathke's cleft cyst in the differential diagnosis. That's the way the histology came back. But what I want to tell you about a Rathke's cleft cyst is very simple. It should be, if it's small, at the junction between the anterior adenohypophysis and the posterior neurohypophysis. They're supposed to be in that pars intermedia. And their histology of the lining is like the lining of a colloid cyst. So if you're an embryologist, it kind of looks like endoderm. But if you think about what a colloid cyst makes, it makes something like mucus. And if you think about a sinus or a bronchogenic cyst as being lined by the same epithelium, you can remember that mucus can be dense or lucent on CT, and it can be bright or dark on MR. And the same thing is true for the contents of a colloid cyst, and the same thing is true for a Rathke's cleft cyst. So if you think you've got a little fluid-filled, non-enhancing cyst in the pars intermedia, that's probably a Rathke's cleft cyst, but who really cares? Because it's probably not going to kill the patient. But anyway, 61-year-old patient, progressive headache, no further history provided, and you see this thing here, which looks similar to something else that we just saw. The lesion is not enhancing. There's enhancement around the outside. It's growing out of the Sella. So, you could give a differential for this, and you could say, well, maybe we're looking at the wrong phase of contrast enhancement, and this is really going to enhance if we do delayed imaging. You just scanned the patient super, super fast and just saw the gland enhancing around the outside. But this one here had this junk inside, this just proteinaceous gunk on the inside, which was consistent with what you could find in a pars intermedia / Rathke's cleft cyst. But they didn't have the lining, so the pathologists were squeamish about making the actual diagnosis. That's just the way it is. So these are true cysts. They may actually be related to the stomatial pouch of Rathke. It's not clear that craniopharyngiomas are related to the stomatial pouch of Rathke, and I have no idea if colloid cysts could possibly be related, but that's something else to think about. But usually they're really, really tiny things. We see them all the time. They can have fluid levels like this one does. The classic sign, if you use your imagination or take drugs, is that you see this kind of target sign. That's published in the literature, that you have this kind of target with something that is more dense and drier mucus that's inside, surrounded by some more watery mucus, which is something that you do see in colloid cysts as well. So what about other lesions that are in the area? So you can have the epithelial lesions, craniopharyngioma, dermoid and epidermoid in the suprasellar cistern. You can have hypothalamic and chiasmatic gliomas, optic nerve gliomas. We saw great examples of those. Once again, don't forget, I hope you don't forget after I said it like 6 times, a granulomatous disease, sarcoid TB fungal in that suprasellar cistern. And then we mentioned about Langerhans cell histiocytosis and germinomas there. So there's 2 different kinds of craniopharyngioma craniopharyngioma just to make your life a living hell. The pathologists use one name for two different tumors. They're starting to be better, but children primarily have the fluid-filled, calcified rim adamantinomatous flavor of craniopharyngioma, which mimics the histology of the tooth bud. So, adamantinomatous comes from the word for ivory, and that comes from the way that the tooth is basically more like ivory. Teeth are not bone, by the way, but I think all of you know that. But these are cystic, and they're primarily going to be in children, but they can also occur in adults. The other flavor of craniopharyngioma is the squamous and papillary. Now it's just called the papillary craniopharyngioma. They are not cystic. They are solid tumors. They don't calcify as commonly, and for the surgeon, they're easier to resect. And one of the things about craniopharyngiomas is that they tend to incite a pilocytic reaction. So they incite an astroglial reaction with pilocytic astrocytes, and histologically, a piece of that reaction from the adjacent hypothalamus may be mistaken for a pilocytic astrocytoma of the hypothalamus. So that's like a bit of neurosurgical trivia, that the reaction to it, in the same way that you can get gliosis around a metastasis and the biopsy of the gliotic rim is mistaken for a glioma, except the lesion enhances and it looks like a low-grade glioma. So 23-month-old boy, headaches for 3 weeks, very common headaches, several a day. Classic presentation. Funny looking thing in the suprasellar cistern with calcification, and sometimes you might see that it has T1 shortening and that it's bright. I remember the Roentgen-Ray meeting was in Washington in the late 1990s, and there were 10 cases of craniopharyngioma that were presented, and they were all hyperintense on T1. And so the pronouncement was, all craniopharyngiomas are bright on T1, and the only thing that's bright on T1 in the suprasellar cistern is a craniopharyngioma. Both are not true, but that's how science progresses over time. But that lipid component, or maybe it's the proteinaceous component, has exactly the right amount of protein to cause T1 shortening, but anyway, they can be bright. They grow up into the suprasellar cistern. Here's the key anatomy if you want to remember something. If you can separate the neural tissue from the tumor, then you can take off the differential list that it's a hypothalamic glioma. If you can't separate the hypothalamus from the mass, then you don't know that the mass is not the hypothalamus. So it's relatively simple, and the coronal and the sagittal images are going to help. The axial images are not going to be much help. This bears mentioning a second time. You know the great American philosopher Yogi Berra, a part-time baseball player, he said the more times you run over a dead cat, the flatter it gets. So just to say it again, if you can separate the hypothalamus and the optic apparatus from the mass, then you take the gliomas off of the list. Now it's going to be one of these other things. So, craniopharyngioma, fluid-filled space. The living part is the lining. Sometimes it's a unilocular cyst. Sometimes it's a very complex list. One of my friends always says if you have something that's really bizarre looking in the suprasellar cistern, start your differential with craniopharyngioma, because they can be very heterogeneous, multiloculated. They can have solid parts that enhance. They can have solid parts that don't enhance. The cyst fluid can have different signal intensities, but something that is in the suprasellar cistern. Now, here's another problem. Pituitary adenomas begin where? In the sella, and then they grow up. So they always have an intracellular component. What percentage of craniopharyngiomas, which are thought to arise in the suprasellar cistern, actually also involve the sella? In some series, it's 70%. In some series, 70% of lesions that actually are craniopharyngiomas are going to involve the pituitary fossa. Look at this example. This lesion is mostly in the suprasellar cistern, but it clearly is involving the pituitary fossa, the sella turcica. So what you want to notice is that the cella is not that enlarged. The cella is close to its normal size. If you had a macroadenoma growing up, where was the narrow part in the snowman? The narrow part in the snowman was right in the middle of those two big parts. And the biggest part was below. The biggest part was down in the pituitary fossa. So if you just kind of dissect the geometry of it, you can kind of tell them apart. So the mass is mostly supracellular, but only partially intracellular. So that tells you it probably didn't arise inside the pituitary fossa. So once again, you want to think about that. Does anybody of you remember this radiographic study that we used to do? The lateral radiograph, the skull series, the worthless thing. You know, you'd come into the hospital with a CNS problem and you'd get a radiograph and an LP because nobody was getting CT scanning except the near dead. So we used to talk about a J-shaped Sella, and this is that example of a J-shaped Sella. And that's because the lesion that's involving the Sella is starting in the suprasellar cistern. It's a craniopharyngioma. So that was an old plain film finding that we used to use. If you saw calcification, eggshell on the plain radiograph, then you would say it was a craniopharyngioma. You'd be done for that patient. So anyway, this is a craniopharyngioma doing that. Something really ugly and heterogeneous in the suprasellar cistern, you want to think about the possibility of it being a craniopharyngioma. So my friend who said that was pretty much correct. So this is a transcallosal approach. So they go through the third ventricle, they fenestrate the floor, they try to be careful about the optic chiasm. They want to go between the chiasm and the mammillary bodies, and they go in and they have this classic lining there for a craniopharyngioma. So what else can we have? Hypothalamic lesions. Most common glioma of the hypothalamus at all ages happens to be a pilocytic astrocytoma. You can also have this weird flavored of glioma called a chordoid glioma, which is thought to arise from the cells of the lamina terminalis. So it's this one of these new tumors. You know, the pathologists like to get together more frequently, so now the updates are coming out every year instead of every 6 years from the pathologist. But this is a low-grade glioma, but it may enhance. And then there's something that occurs on the lateral portion of the third ventricle, a pilomyxoid astrocytoma. Hamartoma, the tubercinarium, and again, we talked about LCH. So I can't find the hypothalamus in this gigantic lesion. It's heterogeneous. It has some rim enhancement. Jim said if it's a big, ugly thing in the suprasellar cistern, think about it being a craniopharyngioma. But Jim also said if you can't separate the hypothalamus from the lesion, it might be a hypothalamic glioma, and pilocytic astrocytomas, even though they're grade 1, almost always show contrast enhancement. So this was a path-proven hypothalamic pilocytic astrocytoma. And again, on the axial images here, this is a different patient at autopsy with a hypothalamic pilocytic astrocytoma. Here's another patient that has a pilocytic astrocytoma. Again, it's a heterogeneous lesion. Look how it's also gone down into the pituitary fossa. So you know, you're looking at this and it's like, okay, maybe this is a craniopharyngioma, but I can't separate it on the coronal or the sagittal from the hypothalamus. So I'm going to worry about that. And then the other one that we always worry about is the hypothalamic hamartoma. Everyone remembers that these patients have gelastic seizures, which comes from the Greek word yelai. It's like gyro. You're supposed to say gyro and not gyro, so it's supposed to be yelastic, not gelastic, but you know, we're stuck with what we are. But this lesion as a hamartoma doesn't show contrast enhancement. So you have the normal enhancement in the pituitary and a non-enhancing lesion there. So that's what we need to worry about. And then the last thing, just for thoroughness to show you, we look at the clivus here, and the bone is destroyed on the CT scan. We have a solitary clival lesion. The patient has no other lesions elsewhere in the body. The lesion clearly is involving the bone, extending backwards into the prepontine cistern. Bulky, lobulated mass. Always think about the possibility of a chordoma. Chordomas typically respect the dura, so the dura is intact there. So what we wanted to talk about, sorry about that. What we're going to talk about, microadenomas, incidental finding or an endocrine presentation, macroadenomas, mass effect. The patient may have bitemporal hemianopsia, different endocrine symptoms depending upon what is secreted by the tumor. The workup for amenorrhea doesn't have to start with imaging. Craniopharyngiomas have a variable appearance, and chordomas almost always have, in my experience, always have bone destruction in the clivus because they're arising from remnants of the embryologic notochord. So thank you all very, very much for your kind attention.